So thank you once again for joining us, and a very warm welcome on behalf of MYT, and we're very much looking forward to supporting you with Day 2 of the second annual Health Campaign Effectiveness Coalition meeting, the promise of collaborative action. We'd like to open with a few housekeeping notes before handing over to Sameen, Babur and Dr. Moredreck, Chibi, who are moderating Session H on digitizing and integration campaign components. So we are delighted to offer today's session in English and French. You will see on the Zoom menu bar the interpretation button. Please select your chosen language now. Thank you very much to our interpreters for your support today. Please be aware that the session is being recorded. You will be able to view the full recording post-event via the Health Campaign Effectiveness Coalition website. Once again, we'd like to encourage interaction. Please use social media channels to promote and engage a wide audience with this event by tagging @HCE Coalition and using the hashtag collaborative action. For today's sessions, please add your questions to the Zoom Q&A, which can again be found at the bottom of the Zoom screen. You'll be able to see questions which have already been posted, update and add additional comments as well. We'll aim to answer as many of these as possible. And finally, the MYT team are here to help you with any technical difficulties you have. Please use the chat facility on Zoom or email the team at events@myt.uk.com. I'm now delighted to hand over to Sameen and Dr. Moredreck to formally welcome you to today's session. So over to you.
Great. Hello, everyone. Welcome to the session. I could share my screen to just show a brief overview of what the session will look like. Claire, I don't think I can share my screen. Oh, there we go. Okay, thank you. All right, welcome everyone. So this session is really meant to be a discussion around the value of digitizing and integrating major components of campaign activities across disease programs. So we're really thinking about the entire sort of planning, supply chain management, training, payments, intervention, delivery, the whole gamut. And we'd love to hear, we're going to be hearing from panelists on where technology can be most impactful to address these use cases, and sort of how we can collaborate as a community better going forward. So by way of an introduction, my name is Sameen Babur. I'm a senior technical advisor at Clinton Health Access Initiative, and I support a lot of digital health work in the malaria and TB space, Mesoamerica, Africa, and Southeast Asia. And I've worked quite a bit in campaigns digitization as well. I'd like to hand it over to Dr. Moredreck as well to please introduce himself.
Thank you very much, Sameen. Yes, good afternoon, everyone. Good morning or good evening, depending on where you are. Yeah, my name is Moredreck Chibi. I am the team lead for innovation, including digital health here at WHO in the Aikpon region. So yes, I really want to welcome you on this session, and as I'll be co-facilitating with Sameen, I think I can encourage you to, to think outside the box and also to provide any insights that you think is going to be relevant for this session. So I'm looking forward to this session, Sameen. I think we do have good cadres that we are going to really enjoy from their insight. Over to you.
Hi, Sameen. Sorry to interrupt. We've just had a few issues with the interpretation, so I'm just going to end it and restart the booths. So just give me just a moment.
Donc nous allons faire redémarrer. Donc.
So I believe everyone should be back in the correct booth now. So apologies for the interruption, and do continue. It's just for the benefit of those watching on the platform. So sorry again to interrupt.
No problem. Okay, great. And so we have panelists joining us who have worked on campaigns and the use of technology in campaigns across Nigeria, Eswatini, and Benin. So now I'd like to ask panelists to introduce themselves, starting with Elijah.
Hello, everyone, and good afternoon from Benin. I'm Elijah Egu, the Senior Project Manager of the Benin Digitization Project with Catholic Relief Services. So far, since over the past 6 years, I've been working on health campaign digitization in Nigeria up until Benin, and digitizing over 16 health campaigns so far. I hope to be sharing a lot of experience that I have gathered, over this year to see how this could contribute to this discussion. Thank you.
Great. Thanks for joining, Elijah. Now, Nazir, from representing some work in Nigeria, could you please introduce yourself?
All right, thank you, Sameen, and hello, everyone. I'm Nazir Halliru. I'm currently the Grade 3 Nigeria Country Manager with Season Columbia University, but I base in Abuja within the Ministry of Finance, but National Planning. And I lead the efforts to support campaigns in Nigeria with national primary healthcare development agencies, and also working closely with the government to improve use of technology in campaigns and immunization activities in Nigeria. Under the core 4 data layers of Grade 3, the population estimate, the settlements, the boundaries, as well as other key infrastructures such as the health facility layers and other relevant data sets to improve service delivery. And I'm glad to be here to share my experience. Thank you.
Great, welcome, Nazir. Over to you, Stefan.
Thank you, Sameen. My name is Stefan Vuyamo. I'm based in Geneva, Switzerland. I'm a software engineer by training, and I spent the past 20 years working on geospatial information systems to support public health programs. 10 years at the World Health Organization, and then 10 years with Novelty, which I co-founded 10 years ago. And I've worked since 2012 on geospatial solutions to monitor vaccination teams going house to house to administer 2 drops of oral polio vaccines, and building geodatabases so that we know where and how many people live in different locations so that we can identify service delivery gaps. And I've been then based on this work working on more complex geospatial microplanning use cases to support measles or malaria campaigns. And since then, I've been working on generalizing geodatabases to power geospatial microplanning for routine immunization, non-polio SIE, and things like that, and also on generalizing the geospatial tracking of pretty much any field activity anywhere on the globe, such as social mobilization campaigns, polio campaigns, active case search, supervisory visits, and things like that. So I thank you very much for having me on this panel as a panelist today.
Great, thank you. And lastly, we have Busi from the Ministry of Health in Eswatini. Busi, would you like to introduce yourself?
Okay, thank you so much, and good afternoon, everyone, all protocol observed. My name is Vusi Logotfago. I'm from the Ministry of Health in Eswatini. I work there as an epidemiologist within the Ministry of Health. So maybe brief about myself. I've actually been involved mainly in NTDs in terms of neglected tropical diseases, particularly doing the mapping of entities in Eswatini and the subsequent interventions in terms of MDA, and we've been having those campaigns since then. And then I think until we're interrupted by COVID, because they're actually school-based. And I think maybe to mention a few of the projects that I've been working in lately, I have actually been part of the COVID response, particularly in the surveillance pillar. and we've been able to actually coordinate surveillance activities, the response, as well as contact tracing. And also we've just concluded our seroprevalence survey to assess the prevalence of COVID at community level. So basically, I'm also hands-on in COVID and actually been doing so for the past, or rather since COVID started in March 2020 in Eswatini. So I'm happy to be here to share some of my diverse experiences in terms of the projects we involved in. Thank you.
Great, thank you. All right, so now that we've gone through all the introductions, I think we can go ahead and jump into some questions for the panelists to share their experiences. If any, please use the Q&A to post any questions or any comments that you might have for the panelists as they speak, and we'll be selecting some questions from there as well. So we'd love to see some input and questions from there. Great, so just to sort of orient ourselves a little bit, we really would love to hear about sort of experiences with digitization across all different kinds of campaign components. You know, we have the geospatial folks from Grid 3 and Novelty, and then we also have CRS that's been involved in a lot of different campaign digitization components. So thinking about enumeration and denominators, operational area definitions, macro planning, micro planning, community mobilization, training, payments, supply chain, monitoring and evaluation, campaign delivery, and supervision are kind of like all different themes within the space that we would love to hear more about. And to sort of kick us off with a couple of questions, first, I'd like to hear from the panelists very briefly, what your experience has been using technology for any of these campaign components. And then in your sort of experience, what are the biggest gaps in campaign operations across countries that you think technology can address and where those opportunities are? So maybe we could start with Elijah.
Okay, thank you so much for the question. I'll start with the first one around my experience with health campaign digitization. I can say over the years, we have seen increased, acceptance on the use of digital technologies for health campaigns, especially in Sub-Saharan Africa, where I work. I will say this because the experience, kicking this off in Benin and in Nigeria was a bit difficult in the first start because we did not get a lot of buy-in, apparently because now this is going to, unveil the gaps in the campaign. This is going to reveal the inefficiencies as well in the campaigns. The second point is we have also seen an increase, data use and data quests, especially from the health actors within the Ministry of Health. Now they are beginning to, appreciate the data more because this is actually helping them to improve the intervention and also the impact of the health campaigns, particularly for LLIN, SMC, and Bunkurias's campaign that I have been working on since the past 6 years. In these countries, we have, noted a decline in the cases of malaria and also Bunkuriasis so far. And in view of these results, apparently the health actors are seeming to agree more with the use of this technology. Now, to go to the second point around the biggest gaps in campaign operations, I would like to say this in 4 key points. The first point is, well, all of these points that I'm listing is from a place of experience Apparently, I'll be speaking with examples. So these 4 key points that technology can address in these health campaigns are: 1, accountability and campaign cost and operations effectiveness. How do I mean? In the paper-based approach, for example, in Benin, where we did like a national scale campaign, and 26,000 staffs were deployed across the different health zones and departments. Using the paper-based approach, it was not effective to track the hours that everyone had worked across the different days of the campaign. But now, using the digital tool, we can, effectively now know who was active per day, how many households he reached, and also the payments are being calculated with this cost. So overall, if we had planned 10 staff in a location for 6 days and only 6 staff have worked for 3 days, it then means that the campaign team will just pay for the 6 staff that have worked for 3 days. So overall, this is reducing the cost of campaigns, over the years, which has really brought a lot of accountability to health campaigns so far. The second point is on data used for prompt decision making. In the past, the paper-based tools will have to be collated after the campaign, and during the review meetings, the supervisors will just take like a sheet of paper and take notes of all the challenges and the point. There is no review, that there is no analysis of this data to identify the challenges and so on, and see how this can be resolved at a national scale. But now with the use of digital tools, you can resolve these challenges. How do we mean? Because we have like indicators being integrated on your data, the dashboards, to in real time, explain to you the gaps within the campaigns per day. So this is a big gap that digitization can close in these campaigns. Now, also the campaigns are timed. How do I mean? In some of the campaigns, it has to be implemented in 3 days. SMC, for example, it has to be implemented in 3 days. Concurrencies in Benin is over a 10-day period. Now, what this means is that you need to do real-time evaluation and analysis of this data to reinform the field teams around the gaps and the things they need to do to improve the coverage rates of the campaign, and also the therapeutic coverage as well of the campaign. The third point is for health campaign planning. Now, without the use of technology in the past, planning this campaign was really, really very difficult. An example is, during the micro planning, all we used to do as at that time is around just, collating the target population information, and all of the operational, requirements at the different levels. And the truth is, we did not even have the basis of data comparison. In the past campaign, how was the coverage? How many people were missed? How many households were missed? But in this current, with the digitization now, you can triangulate the both data from a previous campaign and a current campaign to effectively plan the campaign. Did we assign, less teams in this area? And is this the reason we had low coverage in this area? So, all of these parameters can now be solved with the use of technologies for, health campaign planning. And more importantly, in Benin, we developed this tool called the Health Campaign Management System. So apparently we use one software and one database to implement different health campaigns. So this has, completely eliminated household enumeration across the different campaigns. Now, what do I mean? If we do an SMC campaign now in a specific area, the teams will go and update the population information already contained in the database with the previous campaign. So this means that enumeration across the different campaigns now is now eliminated. Now this is a lot of cost that has been reduced in the campaign. And in Benin, we have done this for SMC campaign and also the Uncurasis campaign. Now, these are big gaps that digitization and technology can close across health campaign planning. Now, the fourth and my last point is on health commodity distribution management. Now, I can tell you there have been a lot of waste and mismanagement over the years, and this is a huge gap in health campaign implementation. Now, all of these points that I'm raising is talking about this at scale. In an example where you are implementing an airline campaign in a country that has about 6,000 distribution points across the country. Now, this 6,000 distribution points, you need to know, if each of these points have available stock per time for each day of the campaign. Now you can get this kind of reports using paper approaches. So around our campaigns, we have integrated the health commodity management module to ensure that this is able to track the entire supply chain across different stores and also the distribution points. So the use of technology will be able to close this gap and ensure that health programs can harness effectiveness. It's going to surprise you to know that in some of the health campaigns, apparently you have stockouts in some regions, and after the campaigns, you see tons of nets still remaining, in other regions, and this net should have been reallocated to these different points. So this is a major gap that the use of technology can close. I think I will stop at this point since my time is up. Thank you all for listening. Over.
Great, thanks, Elijah. I think we can move over to maybe Stefan and then Nazir, maybe 3 to 4 minutes each. If you could just please speak to kind of where you see the biggest gaps and opportunities for technology from your experience and observations.
All right, thank you very much, Sameen. So in 2 minutes before I hand over to Stefan, I think technology has always been the bedrock of how campaigns are being conducted in Nigeria. And then why do I say this is learning lessons from the polio eradication efforts, where geospatial data played a significant role in identifying these communities, and consistent geospatial tracking of vaccinators to ensure coverage. Grade 3 then emerged to complement the efforts with additional high resolution population estimates, health facility layer, as well as other POIs, which of course made it possible to digitize the COVAX maps that we currently deployed in Nigeria to support the COVID-19 vaccinations, and also the measles maps that are currently on the field, to support the measles, yellow fever, and meningitis campaigns. And additional advancement in this space has helped us to kind of think around digitizing or automating this whole effort of micro planning into improving service delivery by the development of geospatial microplanning toolkits, GMT, in our collaboration with Novelty, as well as GTS, which of course tracks vaccinators as well as other senior supervisors to ensure, this coverage and to also ensure, improved service delivery across the service points. And just in summary, some of the biggest points or biggest challenge that I see, or gaps across how technology can address these campaigns. Number one, issues of data falsification. I see a lot of, opportunities through which technology can address these issues, and also vaccine accountability. How does even the health workers, estimate their target population, logistics, and supply chain management, which of course has a positive impact on the vaccines accountability. And lastly, issues around accountability framework. So, like, how do you hold health workers accountable? So I see a lot of input towards how technology can support overall this effort. So especially maybe linking this to payments and linking this to coverage and immunize children. So this will really improve the service delivery and of course improve coverage across the different program areas. So this is beyond COVID-19, beyond routine immunization, looking at it into other campaigns, such as the non-polio and polio SI campaigns. So I think due to the paucity of time, let me hand over to Stefan to share his thoughts around those lines. Thank you.
Thank you very much, Nazir. Yeah, maybe just in a few minutes, just to add a little bit. I've been involved in the building geodatabases, which contains essentially the baseline data that you need to do geospatial microplanning, and then working on geospatial tracking systems so that you can track essentially any type of intervention. So my experience was initially in 2012 when we built this vaccination tracking system, and this whole project, I think, gave birth to Grid3. It was very specific just to support polio in Nigeria. And since then, we've been generalizing this problematics. And so where I think technology can really help, with the biggest gaps in campaign operations is, technology can really automate a lot of stuff. So you can automate a lot of tedious tasks or tasks that are even not feasible manually, like putting everyone on the map. With the use of high-resolution satellite imagery and machine learning, what is being done by Grid3 is like, you can put everybody on the map at national, continental, or even global scale very quickly. You can estimate resource needed to implement a given interventions and things like that, at local or at global, national or continental levels. I think the automation is key in digitizing campaign components. The other thing which I think is really key is the ability, to aggregate and disaggregate or zoom out and zoom in into your either the planning or the monitoring and interventions. For instance, when you see how now microplanning is being done, it's impossible to bring all the paper-based map together and ensure that border settlements will be served, or that a settlement is not going to be actually assigned to two different teams. And with digital data, you can bring a map, really for bottom-up planning into the hands of health workers, but then you can very easily aggregate all of this data and then, run quality checks and ensure that everybody on the map is going to be served. You can also automatically transmit, and I think it was mentioned by the first panelist, you can also automatically transmit data from the field all the way to a centralized location. You can aggregate results on a daily basis. And so it allows you to monitor and course correct the delivery of services in near real time. It's very important for immunization services, which are provided through routine immunization, like a measles campaign lasts 6 days in Nigeria. If you can't course correct the immunization campaign on the next day, well, that's it. At the end of the 6th day, you're not going to reorganize a whole national campaign. And the other two components I would mention that are going to bridge some gaps is the reusability. So you can really capitalize on work that has been done previously. For instance, if you think about those hand-drawn paper-based maps, there are some baseline elements in there that are like the settlements, their names, where are they, the roads and things like that, that are, or the schools and the mosques and the other points of interest that are very important to plan measles campaigns. But you're not going to use exactly the same approach to plan routinization campaigns. When you use paper-based map, you essentially have to redo it every time. When you use digital maps, you can use this base data that you can capitalize on and improve over time and share it across different programs to be able to, specifically use it for your specific use cases for micro-planning. So I think that's going to be key. It's going to reduce work and improve performances. And the last one I think is you can systematize or standardize things. Excel templates are great. Excel is really, really successful and powerful, but it's really easy for people to change it and mess up with data or introduce some data quality issues and so on. When you come up with real information, strong information systems, you can more reliably ensure data quality and consistency of data. I'll stop there. Thank you.
Thank you, Nazir and Stefan. Lucy, over to you. You have maybe 3 to 5 minutes to just chat a little bit about where you see the biggest sort of gaps that can be filled by technology from your experience.
Okay, thank you so much, Sameen. I think the colleagues before me have actually outlined where they've actually used in terms of technology in relation to campaigns. So I must say that as a country, we are actually collecting and upscaling a client management information system, which is electronic based, particularly for routine data capturing within the health facilities. And I think this is actually coming in handy, or rather it can come in handy when we've actually fully digitized all our campaigns. But currently I must mention that where we have not been able so much to actually digitize, but rather we've remained paper-based, and we know the frustrations in terms of paper-based, which subsequently needs to be entered into a system, and we have data quality issues, which we actually have as a challenge. But I must say that, having said that, there are elements, not necessarily speaking to campaigns, but within the entire surveillance space, which fully uses digital platforms in terms of capturing data, particularly the malaria surveillance, if I can speak that one, because it is one of the programs that are actually ahead in terms of implementation of surveillance system, including the spatial analysis towards malaria elimination in Eswatini. The only campaign which I can actually single out in terms of using digital platforms, it's the current COVID-19 vaccinations, whereby we are entering data into iPhones. There is that electronic registration of clients, and actually that has actually facilitated tracking real time in terms of progress and the coverage in terms of vaccination coverage as we move towards COVID control. Now, coming to what I think these gaps could actually address, I've already alluded to the timeliness in terms of reporting. If we actually using those gadgets, for instance, within the vaccination campaigns. So we have issues of data quality in terms of completeness and timeliness. They're not an issue because we do know that we set those limits within our systems. Also, in terms of real-time reporting, we are able to report on a daily basis because data is actually forthcoming. We are able to actually be accurate in terms of our reporting, in the sense that we don't have data issues like I've already alluded to. And then the spatial analysis, sometimes when you lobby or within those platforms, those in power, or rather the political structures, they tend to appreciate pictures. So the spatial analysis comes into place as it relates to them to say, this is where I am and how can I support towards improving. That actually trigger prompt response of interventions, because we see the data, we have the dashboards, and it's actually indicating in terms of whatsoever. So we're also able to triangulate with the other data sources. I've talked of the client management information system, whereby we actually try and link these two so that we pull whatsoever indicators that we have. For instance, within the campaign mode, we also want to know the disease burden. So in terms of prioritizing which areas we go to, so that comes in handy. So the experience that we have in terms of drug and stock distribution and monitoring, I've already touched in terms of the dashboards. So it's a lot of benefits that we see that if we can leverage on the available technology, moving forward, our campaign can actually be fruitful, and we can be able to measure what we've done in a timely manner. I must say that over the past, when we're using the paper base, you would find that at some point we have actually miscalculated our performance because of data quality issues, which this comes and address, and we hope that this we can upscale so that we improve in terms of moving forward towards eliminating most of the diseases of public health concern in Eswatini. Otherwise, thank you so much, Sameen.
Great, thank you, Lucy. And there was a follow-up question when you mentioned the COVID-19 client tracking. There was a question about how you've handled and ensured privacy of client data. And I think just more generally as well, if anyone's sort of has some thoughts to share about just kind of individual patient level data and privacy concerns.
So, sorry, is that for me, Sameen?
Yes.
Oh, okay. So, well, in terms of privacy issues, we generate unique identifiers within the system. So the issue of data quality, when we talk of management and analysis, it is actually purely based on anonymous data, and we also analyze data in a way that it cannot be related to an individual, but rather in a useful approach so that we are able to actually measure the way our country is actually structured. We have got the regions, we've got the Dinkhundla, which we call constituencies. So we can zero down to a constituency level to say what is the coverage within that constituency, and then we can actually factor in or leverage other data sources, like I have talked of the disease burden, to say we can already begin to correlate in terms of the coverage, in terms of vaccination, as well as the disease burden. So that comes in very handy, and that is so possible because that vaccination campaign has been actually carried out within an electronic platform. Thank you, Sameen.
And there's another question, just if anyone has thoughts or experience about sort of potential use cases for biometrics in this space, if it's been piloted anywhere, if it's been considered in any of your work. So general question for any panelists.
I'm happy to try to give some thoughts there. Yeah, there's been some at least feasibility study on using biometrics, voice biometrics, because they are thought to be less intrusive and maybe more acceptable. And maybe, the use case was to, when there are supervisory visits in some places, to maybe try to record the voice of community informants or people that would be trained by those supervisors, and to ensure that when supervisors go back over there, we are actually revisiting the people we enrolled into the surveillance system. But it was just a technical feasibility study. It seemed to be feasible, especially if you include the geospatial dimension, because as the more people you have enrolled, the more the quality of the biometric system, the machine learning system drops. But if you constrain it to who are the community informants which are around this location where we actually enrolled them, you constrained it to that list of possible informants, then the quality was pretty good. But I don't think it has ever been implemented in real scenario. And maybe just if I can also try to answer Amidreza's question for the experience in using digital tools, phones, to capture data during the campaign. So for polio in Nigeria with the vaccination tracking systems, it was done, and so it was actually a lot of essentially the tally sheet was digitized, so it was really at the household level, not just at the settlement at the end of the day, but really every single household, and it was done across the country. The problem with that is, versus the passive tracking, where you don't need to train anybody, but you can at least calculate service coverage very easily at scale. When you want to collect active data, you need to train people, and then it was, the scale to which it could be deployed was smaller. But but I'm guessing now this was back in 2013, 14, 15. Now, people use more and more systems. So I'm guessing you can deploy this at scale more easily.
Great, and maybe Elijah, if you have 30 seconds to a minute to respond, and then Dr. Moredreck will move on to the next question.
All right, thank you. I would be speaking to the biometrics in health campaigns. So in Benin, we used, biometrics for attendance tracking across all trainings to improve the participation in these trainings. Now we learned a lot of lessons with that because I think, primarily the two key points with that is that the first was that the biometrics of some persons changes due to the use of their fingers for work or something, and this might alter their fingerprints. And in some cases, this person had clocked in last month, and in this month it can no longer clock in because of these issues. And also we were to use this for the tracking of children under 5s for SMC campaigns, but also we realized that the biometrics of children less than 9 years old is not properly formed that you can use this at scale. So I think so far we are just using this around the trainings, tracking the attendance during the trainings. Thank you.
Great, thank you, Elijah. Over to you, Dr. Moore.
Yes, thank you very much, Sameen. I mean, it was just music to my ears listening to the great insights from the panelists. I'm going to pose the second question, but just to set the context, you've been really highlighting the advantages of technologies, and I can't agree with you more. But from my experience, deployment or development of a technology and implementing it may constitute, say, 5% to the overall success of the implementation of that project. Here I'm talking about the system in which you are deploying that technology or platform. So I want to get from you, and I would really want your honest opinion on what are some of the considerations and decision factors that have led to effective use of technology, and taking into cognizance that some technology have failed to be deployed, not because of their technical nature, but more because of the ecosystem around deployment of that technology. So I would really want you guys to just run us through some of your ideas, what really it will take for effective use of technology, and also some of those key considerations that we need to take into account. Say, if I'm going to Benin, we're doing this end-to-end digitization and also integrated platforms. Just give us a snapshot of what success looks like in the broader context. Maybe I can start with Elijah.
Okay, thank you so much for this question, Dr. Chibi. I would actually be responding to this question with maybe 4 points, as I did to the first question. So, so far with our experience, primarily because I had led the digitization of airline campaigns in Nigeria before I moved over to Benin. So one key factor that leads to effective use of the technology is high political will and buy-in. Now let's leave the technology aside, let's leave the health sector aside. If you don't have this political will and buy-in, nothing is going to work. And the reason is because it is people who will use the technology. And, if these people, develop a culture of bias in using the technology, you would get, junk data on the platform. And this data will lead and reveal to ineffective information that you will now be using to make, the decisions for the campaign. Now, I'm going to say this with an example from in Benin. Apparently, airlines before 2019 in Benin has actually been, paper-based. And the request to digitize this campaign, it came from His Excellency, the President of the Republic, to the Gates Foundation. So apparently, we did not face any form of, rejection and, opposition in different levels. Although some of the medical directors were like, well, we don't want to use the technology. Oh no, we have our existing systems. We want to use the existing tools. Those are easier for us. We don't have the people who will use the phones. But because this has come in from the president, everybody has to do, everything it takes to digitize the campaign in 9 months. So the thing is, if you have this political will, then the technology will be super, effective in its use. Now, the second point I want to talk about, it's about the donor, coordination and support. What do I mean? In some of these health programs, USAID may be funding a part, Global Fund may also be funding a part, and the Gates Foundation as well. Now, if at the level of donors, for example, the Gates Foundation is saying that, before you will do this campaign, or before we can give you this funding to eliminate uncuriasis, for example, speak with the Global Fund and see how you can use the digital tools to implement this campaign. Apparently, these countries will have no choice but to, adopt the use of the technology. But, if these donors actually come together to speak to the programs to say, okay, going forward, we need to see, effective use of the technology, and then we can fund this initiative, because the thing is, it is very inefficient. For example, in Benin, now I don't see the reason why you need to do household enumeration for measles, and then you return back after 2 months or 3 months, and then you are doing the same for SMC campaign. No, we can do this at once, and then you can use the data for all the campaigns within the same period. So the thing is, if the donors can come together, all right, coordinate more and say, no, these countries, you have to do it this way, else we will not fund these campaigns. I tell you the truth, there will be more, effective use of the technology. Now, the last 2 points I'm going to speak to is on the technical side. Now, as an application architect, we need to design, application that really meets the needs of the program. What do I mean? For example, SMC campaign, yes, they have their coverage rates and so on, but there have been a problem with the SMC campaigns. How do I know that this child who received the first dose is the same child that received the second dose, is the same child that received the third dose? Now you have a digital system, but this digital system is just to collect the data on all of the doses that have been distributed, and also the coverage rate. This does not meet the needs. The actors will not be super interested to use this application. But if you have an application that gives, a unique identification to the children as the first point, and then for each child, I can actually tell that for each month of the SMC, this child received the first dose, the second dose, and the third dose. And also at the end of the 4 months of the campaign, apparently the data can tell me that, yes, this unique child have received the 12 doses of the campaign. These actors will be super, super interested. Why? Because the technology is meeting the needs of the program. And with this now, they can, calculate things like, therapeutic efficiencies and all of that. Why? Because they have, they have more information that they can use. Over the past years, what we have seen is, digital tool just replacing the paper tools, but we need to see the added advantage. So, over the years, I've actually been scoping and designing, indicators on digital tools to reveal more, just beyond what the paper tools, have actually been showing in the past. So I think this is a critical, factor that is going to lead to, effective use of the technology. And on my last point is just a minute, developing technologies with high effective monitoring and supervision abilities. Now, how do I mean? Apparently, okay, I think the key focus around the technology has actually been, data, coverage rates, and so on. But I just want to give you one quick example. During the SMC campaigns, it's actually implemented, during the raining season. And reading through the reports of the past years, they have had issues of rainfalls. And this rain is very, very interruptive to the campaigns. Now, this was not included in the scope of digitization. However, we now look through and say, okay, if this is a problem in the program, then let us, create like a weather forecast tool that will help the teams to tell them that, okay, if you want to go out to work on this day, then you have to leave between, let's say, 10 a.m. to 2 a.m. Because if you don't go out at this time, any other time afterwards, okay, there will be rain today. Now, this tool is going to improve supervision. It's going to improve, what's it called? Monitoring. And then coming up with indicators that can pinpoint things like inefficiencies in the program will really lead to the effective use of the technology. But now we just have basic platforms that will just tell you, okay, here's the coverage rate, this is what is happening, these are the geolocation where things are happening, but we think we need more. All right, if we keep doing more, then we think that this is going to call the interest, of a lot of stakeholders to see how this will lead to more, effective use. I do have more points, but because of the sake of time, I think I will just stop here. Thank you all for listening again.
Great. Thanks a lot. And I'm not going to mention you by name, colleagues Nazir, Stephanie, and Vusi. Anyone who think he can also jump in to complement what Elijah has said. I think he has mentioned really, really good points. One to do with political will, alignment of the donor community, I think is very critical. And I like the needs-driven approach. You need to contextualize your technology, as well as, of course, integrating the monitoring and evaluation side of things, which I think is very critical. And I've also seen that many of these technologies, they don't have the evaluation of the monitoring component, which I think is also key. Please, Vusi, jump on.
Oh, okay, thank you so much. I think, like you said, I just want to come in and add, maybe probably from complement what he's actually said, my colleague has said. I think in Eswatini, we always say, do things with us, not for us. So as long as you can come up with nice technologies to the kingdom of Eswatini, as long as you do not involve the teams from the inception, if I say from inception, I don't mean from the point of development. I actually mean from the point of adapting, or for the point of accepting that technology. You fully involve the teams. I'll make an example. We attempted to use tablets in terms of mass drug administration in 2017. But the problem is we came in with it from the national office to the regions, and the regions completely rejected it because we came with it at the time of MDA and we had not yet consulted them. So they felt this thing will come in and waste our time because of 1, 2, 3, and 4. You could actually tell that we do not have a buy-in from them. So for me, I think the stakeholder involvement is very, very, very critical in terms of doing so. One other which I would like to add, in as much as we'd appreciate the technology that would come in, do we have infrastructure to actually host that technology? For instance, we may talk, because we want ultimately at the end of the day to talk of real-time reporting. So that speaks to connectivity issues. Do we have enough bandwidth or broadband to actually adapt, or rather, what can I say, to actually allow us to push the data in real time so that we do not suffer the same fate as in having to actually work and then submit at a later date? So I just wanted to add that from what my colleagues have shared. Thank you.
Excellent, excellent. Thank you so much, Vusi. I think this is incredible. Thank you so much. Nazir, please.
Yeah, thank you so much, Dr. Moredreck. So I think just to add on the previous speakers, so in our case in Nigeria, I think some of those factors that have led to the effective use of technology, I can trace this back to history around 2011, 2012, when there were a rise in the cases of polio virus in Nigeria, especially in the northern states. So this, left the government with no decision than to really, adopt the use of the geospatial technology to really identify, where are those under 5 children and where can we trace them and what mechanisms can we use to really track them and to ensure that those communities are really, really visited and those 2 drops are being given to those under 5 children across those communities. So I can remember then it was when we started, all this geospatial technology in Nigeria, particularly in the northern states. And then I could remember vividly, the honorable ministers of health then, as well as the leadership of National Primary Healthcare Development Agency, how to really, together with other partners, to really, deep dive into adopting this. So this is a factor that has led us to all the successes that we've recorded in the polio space in Nigeria, and currently riding on that. And later on, we've also seen, consistent increase in the number of unimmunized children. And this is still the same case that we're facing in routine immunization, as well as other polio and non-polio SI campaigns. And this, of course, led to Gavi's 5.0 global agenda, for the zero dose children. So these factors, including consistent mix of communities, has really made Nigeria to really think, outside the box in terms of really leveraging on these technologies, geospatial technology, as well as other digital, platforms to really reach those unimmunized children, as well as visit those missed communities that are consistent, that are consistently being missed across other campaigns. But achieving this has always been in line with some challenges, and I can relate this to some of the constraints that we're currently facing as a country, and of course, which I think is cross-cutting across other African countries, is issue of capacity gap. Technology has always been the drivers of reaching those unreached children, but capacity, for how this technology could be used across these health workers, especially the local health workers, has always been an issue with us. So there will be need for an exit, for maybe training and retraining for them to really imbibe this, for them to really adopt this. Because it's more of like a paradigm shift from the traditional approach that they've been using or they've been adopting for several years ago. And the other factor, which I think is also a very critical issue to us, is inexorable workforce at all levels. So this has to do with, health workers trying to use the same approach that they've been using over the years and not really, accepting change. And there may be, maybe due to reasons around, because the technology is going to expose what they've been doing, or maybe the, consider immunization activities as a way of, getting income, not really focusing on the main agenda to really look at those children, to really look at, those mixed communities. But of course, to them is more of like a business as usual. So if you bring a technology, it's going to bring an end to this usual business that they consider, as part of the system. And the other factor is leadership and governance, which of course has to do with what Elijah has earlier mentioned, the political will. I think I am re-emphasizing this because, it has to do with how coordination happens at all levels. You can have a good plan at the national, but coming down to the state, you find another different perspectives, and going down to the local level, to the local government or to wards, or even directly to settlement or health facilities, you have inconsistent system. And this leadership and organizational structure has always been, a great factor that affects how these technologies are being effectively used, and then how we can really track them in order to achieve our global agenda. So I think due to paucity of time, let me hand over to Stefan. Maybe you can add 1 or 2 points on this as regard to Nigeria experience. Over.
Thank you very much. Yeah, no, I can't agree more that with everything which was said so far. I think it's very comprehensive. Maybe since I'm a software engineer, I'm just going to give some maybe 1 or 2 example real time, like to your second question, what real world challenges and constraints have led to ineffective use. I think the what we've seen is, and it's to Adidja's point as well, it's hard when you design an information systems to decide what goes into the information system, but also more importantly, as importantly, what doesn't go into the information systems. For instance, you could over-engineer the thing and really try to do a micro-planning which tells you exactly which team needs to go to which area on a given day. And we tried that in Nigeria, and it wasn't really practical because, of the reality of the field. Everything changes on a daily basis. So in fact, that needs to happen, but maybe outside of the information system, throughout the health system. But in the information system, it's good enough. It's fit for purpose to simply know what are the areas targeted and then monitor whether they are targeted, and maybe for how long. But you don't necessarily need to try to keep track of which team was supposed to go there. You can leave that for the outside of the system, to the health system itself to organize itself. Otherwise, it's really too heavy to try to keep track of all of that. And then you lose too much work, and then there is resistance and not adoption and so on. So it's hard. It's hard to decide what goes and what shouldn't go into the information system. And I think the second example maybe I want to give is, this sort of tabletop exercises versus really bottom-up exercise. So when you do a micro planning and you try to, name things from, behind your computers and so on, well, maybe it sort of relates to the political will, but in fact, it's really at the local level. Health workers will not be able to relate to the place name we've put on this micro plan, and it's not theirs, and they cannot use it. And so that's something also which, some errors that can be done, and then you can invest a little bit of time or maybe too much time trying to name things remotely. But in fact, I think you need to put it in the hands of the health workers for best, so that acceptability. I think I'll just stop there because, the other panelists really covered everything else. Thank you.
Great. Thank you very much. I can't thank you enough, colleagues. I think this has been excellent. Additional points that actually emerged in addition to what Elijah had alluded to. I think stakeholder engagement is very, very key. Thanks, Lucy, for bringing that. We normally hear a saying that goes, anything done for me without me is against me. I think that's pretty summarizes it. And another thing that I think is of critical importance that has been mentioned is look at the capacity in terms of what is the infrastructure that is available, which your technology or your platform can ride on. Look at, if you can't develop something that requires 5G when we have 2G capability at country level. So that contextual understanding, and also determine the maturity level of technology at that specific context. And also because communities are the ones that are going to use or the beneficiaries of the technology. And in most cases, we relegate them not to be the co-creators in developing that solution. I think community engagement aspect is also very, very key. I had also capacity building or capacity gap because of the disparities in terms of either skills, literacy level. So when a technology is being developed, one needs to understand who is it developed for, who is going to be using this, and does the person who is going to use it has the requisite skills and expertise to make sure that that technology is implemented effectively. And another point that I was actually laughing at, which I think it's common in Africa, this issue of culture change. I would really want to say, when a system has been working for you, or regardless of the level of inefficiency, because you're probably getting something out of that from a very corrupt, you're taking advantage of a corrupt system, if I may call it, that switching costs can have implications or repercussions. So you may see that that person is a decision maker, but may either delay improving that system because of personal sort of gains. I think that's something that we definitely needs to be reflected. And that's why probably the president would really need to come in and say, this is what I need to see in 9 months, and it should happen that way. And I think that's probably sort of a language that some of our countries may also understand. But yeah, and the last point on leadership and governance, I think that's very, very, very key, and also to align in terms of the approach of either delivery or whatever. I think that's very key. I think, to be honest, it was music to my ears listening to you, and I've really enjoyed it. And thank you very much, colleagues. So Sameen, let me hand it over to you just to conclude. But thank you so much for this opportunity. Over to you.
Sure. So we have 3 minutes left. We have a hard stop at the 10-minute mark. We have one more question about just tackling resistance when introducing technologies. And I think, Sapan, you had also mentioned a point about cost effectiveness as well, and sort of making a case for how technology is indeed cost effective once you start to sort of streamline across programs and reuse something like a common geodatabase. Could you speak a little bit to that?
So the resistance, Amit Reza's question, the resistance to introducing new technology, this is tough. I think it's really the country. Sorry, Sameen, do you want to?
No, sorry, go ahead.
No. Yeah, I think it's really the toughest one. I think it was really well covered by our moderator Vusi, and also Alija. I think it's really top level, top level people who needs to be onboarded and they need to push it. And then for the second question, the time needed to use the phones and the skill set and so on. I think this is really where we are really at novelty with the innovations we are doing with different partners. It's really this using the geospatial data that has been generated with Grid 3 increasingly for a lot of countries. And I think it really can change the face of public health by simply passively monitoring where field staffs are going and just computing geographic coverage to be able to send people back, So there is no training needed. You can really deploy at scale. You can really, and that, there is no resistance there, except like Nazir said, maybe because it's going to change a little bit behavior, because it's going to bubble up some things that shouldn't be done this way or that have always been and now are part of the system. But I think it's really those two things. But it's tough. It takes time. Change management takes time. Changing culture and behavior takes time. But we'll eventually get there. For the campaign effectiveness, I think maybe we have 1 minute. I think I'll just put my 4 top to-dos that I think the HCE can do here in this chat. But I think it's like training, capacity building, and awareness building. People need to understand more and more GIS. We could standardize a lot of data collection templates and so on to be able to build a map across those that can be used across those programs for micro-planning and monitoring. There's this cloud hosting, the infrastructure that was mentioned. Maybe there's some awareness building that needs to be done around cloud infrastructure, how secure it is, where is it located, and so on. And data sharing agreements. I think open data initiatives are key. A lot of governments in the developing world are embracing this because it's public money, public data. So it should be put back into the public domain. That would really help a lot of people. And then maybe co-financing information systems to break the silos. We have a lot of constraint where we get budget, which is earmarked to a given program and to a given objective and deadline. And that doesn't allow us to write generic systems. We really have to be very creative to be able to bring back some generic stuff into generic systems. So that really is key, so that those information systems can be given for free to countries, but also they can be maintained like ODK. I think you speak to that a lot. It's really hard to maintain and sustain open source software, which is free. And then documenting best practices around micro-planning, top-bottom performance would be key. I'll stop there. Thank you.
Sameen, would you like to do any closing words just before I step in?
Thanks everyone. There's clearly a lot to talk about and not enough time for this hot topic, but I understand we're over time and everyone needs to move over to the closing.
No, thank you very much. There are some discussion tabs on the virtual platform should anyone wish to continue the discussion over there. If not, thank you very much for everyone for joining us. It really was a great session, and I can see that you could talk for much longer about this if you had the time. So we'll now be taking a short 10-minute break before moving over to the closing plenary, the promise of collaborative action, and the panel discussion, perspectives from HCE leadership team. So thank you again to everyone. I'll now close this session and look forward to seeing you in just a few minutes. Thank you.